Hi, my name is GH743 and today in this interview video for the consultant position at Treatments for All, I would like to present my recommendation for the case study that was given beforehand. As a background, I did my Master's of Public Health at Boston University and I have 5 years experience working in quality improvements in lower middle income countries. Before I dive right into my recommendation, I would like to give a brief explanation based on my understanding on how the current patient flow works. So, the patient comes to the clinic for a medical visit. Then, the patient will hand over their blue card to the register, and the patient's information in that blue card will be handwritten into a blue book. The blue card also is used to locate the patient's file. The patient will then receive their file along with a queue number. Then the patient will queue to the first nurse to be checked, their vitals, and recorded. After their vitals are taken, the patient queues again into to the second nurse for the data capture, and then after their vitals were entered into the system, the patient will then queue for their appointment. If a laboratory test is needed, the patient will then go to the blood room and have their samples collected, and their samples will be taken to the National Health Laboratory Services. This process may add up 6 hours depending on the type of the test requested. After the results are received, the patient will return to the doctor and they do not need to wait or queue for the second time. After their appointment with the doctor is complete, the patient then waits at the pharmacy. After the patient receives their medication, they will then schedule another appointment and leave the clinic. So there are a number of points where the patient has to wait for a long time, such as waiting to give their blue card to the registrar takes about 48 minutes, waiting to get their file and their blue cards back and a queue number takes about 15 minutes, waiting for the doctor takes about 1 hour and 21 minutes, and waiting at the pharmacy to get their medication takes about 1 hour and 9 minutes. So my recommended action as the most feasible without adding medical staffs is to cut waiting time by eliminating waste and over-recording patient data. First, it would be wise to skip writing the patient's information in the blue book so that the patient directly leaves their card at the register and obtain a queue number and receive their card and then will receive their card later on with their files with them. And second, to shorten the time patient receive the files, I think it would be wise to evaluate how the files are organized. Is it nicely sorted? Is it by name, by age, or something? We need to look at it. The easier to find the files, the shorter the length of time waiting for the patient. And if feasible, later on, we could start shifting to digital patient records using open source software that are currently available at the market, which obviously will save a lot of time and it's automated and the patient will not need to queue for quite some time. In terms of how to implement this, we would first create a sense of agency. So, sense of urgency can be built among the clinic management team by presenting the average patient waiting time and patient satisfaction. When the management team starts to acknowledge the gap and identify where quality improvement is needed, then we can move on to implement changes. Second, we should communicate the changes, so registrar staff should be notified of the current changes, train them with the proposed change, and we can also add a banner or some sort of publication near the registrar, like a new patient flow sign, so the patients can read. And third, we also have to reevaluate. So quality improvement is a continuous process. We should reevaluate if the new flow had reduced significant waiting time or not. I hope that gives you an idea of what I think could work at Treatments for All. I'm very excited for this project and I look forward to working with all of you. Thank you.